you. I'm board certified in the state of California. All right, everybody, welcome back. So I would imagine and hope that our first session brought up some questions, right? Maybe a little bit more than what we thought of originally. But what we wanted to do in this time is talk about some of the things that maybe we don't necessarily get a chance to talk about in our programs as we're preparing to wrap up and go into whether it's a clinical practice, an academic setting, or any of those spaces, but how do you essentially advocate for yourself as you transition into whatever role it is that you're going into. So as you've heard between all of us, we've got a variety of settings. There's inpatient, outpatient. When we say partial hospitalization, do we know what that means? Because I want to make sure that we're not using jargon and we're speaking the right language, right? So people are going into a program, they're a higher acuity than outpatient, but not so acute where they have to stay overnight, so they get to go home. Intensive outpatient, where maybe they have therapy for longer chunks of the day, so 3 or 4 hours, 3 to 4 times a week, but again, not in the hospital. Traditional outpatient, we do some school-based work or have done some school-based work. I do some school-based work right now. I'm a health teacher right now. But like the way that you build yourself, you build your business, you build your practice. We have, so I have my practices. Dr. Lara has her practices. People are considering developing practices. Dr. Bounds has had practices, and Shelby is thinking about it somewhere along the line that it's something that he may want to do too, and it's something that you may be thinking about as well. So as we're thinking how we move forward, as we step boldly and bravely and proudly into the roles that we have and the roles that we want, what are we doing? First off, and when we were talking about knowing yourself, I'm being very serious, and I know that we all mean it when we say, like, know yourself, like, honestly. And sometimes it's hard to take a look at ourselves, right? It's hard to look at us and say, like, this is where I might not be as strong. And some of us, as you're transitioning to practice, the idea that the buck stops with you, because it does, and it will. The buck stops with you because you are now the person making the treatment decisions. You are now the person writing the treatment plan, making the med recommendations or the therapy recommendations, and seeing the follow through. It rests with you now. You're not just, and I don't say just as a way to minimize the work that a registered nurse would do, but you're not just following orders. You're writing the orders. Right? You're writing the prescriptions. You're recommending the therapy. I wrote a prescription for somebody to take a walk outside just because they needed to have something written down that Dr. Josey told them to do. I didn't have to send it to the pharmacy, but like they needed me to write it down to tell them to go do it. So having that ability can inflate some heads and some egos, as we may have seen in some of our colleagues, I'll say, so that like having that authority or in some ways power can go to our heads a bit, but it can also make us feel like we're more responsible for things than what we actually are. The reality is the clients that you work with are doing the work. You are their guide. Hildegard Peplau, right?
Yes.
The therapeutic use of the self. We are the tools. And whether that tool is to sit and listen or write a prescription or just be someone to give a different perspective, me and my way of being, even if I'm a little goofy sometimes, me and my way of being is a therapeutic intervention. For the clients that I work with, and in a number of settings. So we've got a variety of settings to talk about. Some people asked about private practice, outpatient, but some of these things that we have up here about your licensure and things that you can negotiate in your contracts, I think we wanted to at least touch on, so that as you're prepping for, excuse me, not enough coffee or post-nasal drip. And like, as we start working into like, what does your contract look like? So you mentioned, Dr. Browns, you mentioned having somebody cover your DEA. Could you talk a little bit more about that? Like, what does that mean for you? Or what did that mean again?
So, as I mentioned earlier, in Illinois, I covered my own DEA, and it's so funny that it's like $800-900 because I remember when it used to be much less than that.
Or it lasted longer. It was like 5 years, 7 years.
Yeah.
Now it's 3.
And it was, less money, more time. And then the next time around, it was more money, less time, and we'll see where it heads. And so it's definitely an additional expense. And so depending upon where you're working, as I mentioned earlier, working for the state actually they were able to pay for my DEA. And so I think with, and we'll get into some of this in terms of negotiations, these are things that you might ask for when you're negotiating the role in the setting that you're in. So for me, because I was moving towards more of a research career and my practice was minimal at that point, it made sense for me to agree for them to pay my DEA because it was really the only place that I was using and needed it. So that worked out for me in terms of the state providing that.
Go ahead.
Yeah, I'll just say, so our practice in Tennessee paid for my DEA as well, but you still had to pay for it upfront. Just another part of that, depending on your contract, sometimes they will pay for your DEA, but if you decide you want to leave early, then you would have to pay that money back before you leave. So just be mindful of that if you do want to negotiate that in your contract.
Read all the fine print.
Literally just gonna say that. Right, so in your contracts, there'll be, it's the scope of your work, what you're gonna do, where you're gonna do it. They like to sneak in lines like, and other services as needed, like when people are on vacation and stuff and they wanna pull you to cover this place or that place, and you're like, that's not what I signed up to do, and they're like, in your contract it says, and other services as needed. You signed it, right? So they can pull you to to have you do something other than what maybe you initially thought you were coming on board to do, because they have needs as an employer to fill, right? There are things like getting so the upfront expense, if you were just like, we're gonna use round numbers, right? Your initial license. So wherever you are, you have to have your RN license and your NP license. All right, that's about $200-300, right?
$400. And your controlled substance license.
Your controlled substance license. That's about $200. Your DEA, $988. I can't math right now, so somebody write that. Like somebody do math, right? But we're getting into the thousands, right? Just to be able to practice, paying for your certification exam, right? You had to pay for that in order to get your license. So that was $295. Although there is a discount, I'm just saying, if you happen to be a member of the American Nurses Association or American Association of Nurse Practitioners, there is a discount for your certification exam. So there is a discount code. The DEA, other things that you might consider when you're looking at your negotiation package, how much time are you going to get off? Because this is going to be hard, right? So what's your PTO? Now, if your PTO is 15 days, how many holidays do we have in a year? Roughly about 8, 9 that a practice might be closed where you might be off. That just took a chunk of your PTO, right? If you wanted to be off on holidays with your family. So then maybe you have a week left.
And I just want to add, my first job was inpatient psychiatry. In my contract, it said one weekend a month. That's fair, right? That's what I thought. So guess what? I had 6 days off a month because that weekend I never got days off during the week. So that I was working that weekend plus my weekdays. So just read the fine print,
Right.
and ask the questions and have them change it.
You actually can, believe it or not.
Yes, negotiate. I think that was one of the questions. Can you negotiate? Absolutely. You should negotiate everything.
One of the things that I would also say, because I watch message boards and I look at like salaries and things like that, and people are like, is this a good salary for wherever? You have to look at what the cost of living in the place that you are, because a high salary in one state may not be high enough in another state because the cost of living is so high. Where I get sort of like, oh, this person is going to get in trouble is when people start talking about like, I'm not taking anything less than $200,000. Oh, okay, great. Take $200,000, but know that your productivity has to cover that salary. You have to be very productive. They have to be able to bill enough to cover that much of your salary, whatever time you're taking off, your health insurance, if you have health insurance benefits, 401k, any of that stuff. Like there's a whole compensation package. And just like if you were going into academia and trying to negotiate like time that you weren't teaching or time, protected time for your research or any of that stuff, you could also look at, maybe I'm not necessarily looking at a dollar amount, because you know what happens when you make more money? You pay more taxes, right, guys? You pay more taxes, so you make more money. But if you negotiate an extra 2 weeks of time off, you've got less time that you're working. You've got more time for yourself. You've got more time that you're engaging with your family. You've got some downtime for breaks. Are you getting time for your PTO? Or, not PTO, I mean continuing ed, right? Like, so sometimes places will negotiate and cover continuing education. Because you need continuing education to cover your license, to maintain your license. So it's to their benefit for you to maintain your license so that you can keep your job there, right? How many days of continuing ed do you get? Because if you get continuing ed days, but that's considered part of your PTO, you've taken more of your PTO time. So that should be a separate bucket, continuing ed time, or they're reimbursing you for continuing ed time. The only other thing that I would say about the contracts, and we'll get into non-compete clauses because those can be really, really, really scary. But as you're looking at the contract, keep in mind everything that you get them to pay for, they own for you. So me and my space, and I can only speak for myself in this, I paid for my stuff. I paid for my licenses, I paid for my DEA, I paid for it because then it was mine. And if I wanted to go do something somewhere else, they couldn't tell me that I couldn't do it because they had paid for it. They couldn't take the money back, right? Because I had paid for it. I paid for my continuing ed and I paid for my continuing ed so that any decision that I wanted to make, I was able to make on my own. But I recognized that I was in a position to do so. Not everybody is, and not everybody will be, especially going into a first job after being in school and not working and I need to make a living, right? So knowing where you are and knowing what you can do, what you can trade, what you can't, those are things that I think are important. We did want to touch on non-compete clauses because they're very important in the contracts as well. What have you guys seen?
Well, I used to work, I helped develop a program at La Comunidad Hispana, which is LCH, focusing treatment on migrant workers. I developed integrating a psychiatric mental health nurse practitioner within their practice. So I did all that, and then I was like, well, why am I doing all this for them? And people keep coming to me to do this, let me just do it myself. Because of the non-compete, I had to leave that job, which is fine. But you have to be aware that that can be an issue because I was a direct competitor to them. I was the only provider and they still haven't replaced me, but still I had to leave and let them know. Because if I would have just done my own practice in the same county, it would have been an issue. I would have had a legal.
So just to rewind a little bit, do you all know what non-compete clauses are? I'm seeing nods.
We're seeing nods.
Okay, good.
Anybody saying no? It's fine to say no. Like, this is
Yeah.
a place to be like, I have no idea what you're talking about. Somebody please tell me. All right, so I'm just gonna put it out there. A non-compete clause is something that a company will say, like, you cannot engage in same services within, and a lot of times they'll use mileage, right? They'll say within X number of miles. If they get sneaky about it when they're like, within X number of miles of any entity that we provide services to. So, imagine this. A company sets itself up in, I'm just gonna pick New Jersey because I grew up in Jersey, so I'm like, all right, south, middle, north, right? A company sets up in central Jersey and says, you can't compete with you can't do the same services or, compete with us anywhere, work for any other organization within 25 miles of any of our locations or any location that we contract with. What do? They set up a satellite office down South Jersey. They have another office up North Jersey. What does that mean for you? You're not working in New Jersey.
And so there's also two pieces of it, right? There's location and there's time, right? So there can be a non-compete while you're employed, but there can also be additional time after you're employed that you can't then go work within a certain radius doing the same thing. So you have to be careful. Again, we'll probably say this a million times, like read the fine print and negotiate it.
Yes, you can take it off. You can tell them, I'm the only one in this county. I'm the only one providing the care. I take the non-compete out. After I learned, my contracts take that off. Know your worth. Also, know your labor laws. I had a job where I signed one before I knew what that even meant. And then when I was looking to get another job, I was like, oh my gosh, I can't do this. But then I just checked really quick. In California, it just says that like no job can stop you from performing your profession, essentially. And so and also just as an occupational health nurse, know your labor laws, know your rights. But I do think that it can be very intimidating, and especially when we get people who are working in rural areas. Like everyone says, know your laws, and then also just state that you don't want to do that and you don't want them in your contract.
So it can be taken out, and it's also just keep in mind that sometimes it's while you're working for an organization, and and then it's also, it'll be like you can't poach clients, right? To them, it's like you can't take your clients, but clients have choice. They have a right to be able to go to whatever provider they want to. So should you happen to set up an organization somewhere, it's not like you can go and knock on their door and be like, hey, guess what? I moved my spot over here. But clients are smart. They can find you. And if they find you on their own, there isn't a reason that you can't see them. So I would just let you know that that's there for you too.
I just want to add before the question that this piece about negotiating being very intimidating, that is probably the most contact I have with my mentees in this program is once they graduate and they are moving into practice and they are negotiating that first contract and they're in it and they're living it. that's when my mentees and I are talking the most, because we're going back and forth about the negotiations. Because, they start off as a new grad saying, well, can I ask this and can I do this? And I'm like, absolutely, and think about this, and this, right? So lean on your mentors and other people in your network, in the alumni network, to ask these questions and feel confident in negotiating these contracts. That's why we're here.
Thank you.
Just a couple of questions. I'm Uriah, and just completed my second mental health nurse practitioner. All right. So a couple of questions. I wanted to go back to the DEA point. So if a company pays for your DEA license and it's only for their company, does that mean you cannot take a second job somewhere on there and use that same DEA license?
It depends.
It depends.
Okay.
It depends on the contract, right? So the example I gave was for the state.
Right.
And so, UC had that as part of their stipulation that you can only use it for them. It depends. You might go someplace else and they might not have that stipulation. So again, it's something that you need to know prior to deciding if it works for you.
Okay, makes sense. And the second.
So I was just gonna say something about that. I didn't know that. So I did not know that if I took a job in another state that I had to have another DEA. But through that process, I learned that, I needed a DEA for my California job and I needed a DEA for my Washington position. So I couldn't, now if I had been leaving my Washington position and going to work in California, then I could have switched, I could have transferred that DEA over to California. But because I was keeping both, I needed to have two separate DEAs.
Oh, wow.
And they paid for it. You guys didn't pay for it?
Yeah, we know you get everything free, Teresa. My second question had to do with the professional liability insurance. Do you suggest that even if our wherever the employer pays for liability insurance, do you still suggest that we get our own personal liability insurance, or you think that's adequate with what's provided by the employer?
Go ahead, Shelby.
Me personally, I would suggest yes, just because it's always good to have backup just in case something does happen, especially depending on the standards of practice of wherever you work at. I know sometimes companies will say, oh, you can't have your home liability insurance, but if you can, I would suggest you actually get it, especially being a new grad.
I'm gonna tell you a little story. I used to work at an inpatient drug and alcohol rehab. Had a patient, I'm not gonna give too many details because this is actually still active. I was on call. I gave the on-call orders. The patient died at that facility. I never touched the patient. I just gave verbal orders. The family sued. I'm involved in that lawsuit because I gave the orders when they came in. I have my own liability insurance. Yes, they covered me, but I had my own. So I had my lawyers now checking up on them. Okay? They wanted my insurance to chip in and to pay out. I said, absolutely not. So that's where we are right now. It's not if it's gonna happen, it's when, right? That's what one of my mentors told me. Just cover yourself. Don't trust people just because they say that they're covering you. That's why I left, because they were doing some shady things. And now I'm dealing with this. It's been 2 years. Never spoke about this before until right now.
So they're covering their own interests.
Thank you. But guess what? If I see something that's not right, I got my people that are gonna say no.
Yeah, I was gonna say, I do legal nurse consulting, so I'm the one that they call to review, typically when there is a nurse practitioner involved in a case, and just to to add to what Daisy is saying, they come for everybody. When that lawsuit comes out, they just cast a wide net of anyone involved in that care.
But what's funny is on the lawsuit, the physicians are not named.
Mm.
The only two nurse practitioners named are both of us, female of color, women of color, and the facility. At that time, I was a W-2 employee, so I was part of the facility. However, I was named, not the medical director,
Facility.
not the physicians who actually laid hands and saw the patient and did the psych eval. No, me, the one that gave the orders coming out. Does that make any sense to you?
No, well, yes.
You know what I mean? So these are questions too I didn't know when I was doing, when I was on call. I didn't think that would ever happen.
Mm.
There's protocols. I didn't create the protocols. So.
I have another question.
Hi, my name is Tiffany. I'm a graduate of University of Alabama. I have two questions. The first one's related to the DEA. Do you need the controlled substance license and the DEA?
Yes.
Is it necessary in all states?
Each state is different, so that's why you have to know what the requirements are for each state that you're practicing in. Some states may not have a separate controlled substance license, but most of them do. But you do need to have the DEA and a controlled substance registry for wherever you are. So
And the
even
second-
if you're like practicing in more than one state, you have more than one DEA, more than one controlled substance.
And the second question is kind of related to what you were talking about. I wanted to ask because a job opportunity came up, but the psychiatrist pretty much gave me the offer. He was in a lot of lawsuits, and I was kind of scared to take that offer. If they're dragged into court, will you be actually a part of that?
So I want to go. I told my lawyer that I would want to go because I'm basically, I guess they want to settle because they know whatever they did, they want to settle. I don't, because I was thrown into something. I'm not going to say I did something wrong when I didn't. So I would be fine going to court because I know what I know and I know what I did. But yeah, you would be. And
So
when
that's
you
if
sue
you-
somebody, you can sue anybody. Like the family could have sued the person at the kitchen. They could have been named on there. So you can name whoever you want.
Okay, so that's if you have a collaborative agreement with them or if you're just working with
My
them?
collaborator was not named. He's the medical director. I was.
So one of the things that I think this is bringing up, and just to clarify a couple of points, or like, are we out of time? No. So if you look at professional liability and you look at the liability insurance for an organization that is providing you coverage because you work for them, right? You have to recognize that the primary focus and purpose of that liability is to protect the institution. It's not necessarily to protect you as the individual. There are some places that will try to tell you that you can't carry your own coverage. You have to decide if you're comfortable going into that, but know that if something happens, the professional liability, the attorneys, the insurance, they're going to look for where was there an issue, who can we lay it on potentially, and like, how do we protect the company that's paying us, right? So they're protecting the organization. They're not necessarily protecting you. Your own professional liability is meant to protect you. So that's something to keep in mind. It doesn't matter if you have a collaborator, don't have a collaborator. And one of the things that I would tell you to protect yourselves, know the clinical practice guidelines. Look them up. I mean, there's clinical practice guidelines for depression, anxiety, for child and adolescent mental health, all that stuff like that. Because even if they're out of date, and Nina, I made you look them up, right? Even if they're years old and not necessarily current, if you are pulled into court, the first thing the lawyer is going to ask you is, are there practice guidelines and were you following them?
Right.
And if you weren't following them, what was your rationale for not following them? And you need to know what your rationale was. Your rationale could be, well, that practice guideline came out in 1998, and there's been a lot of changes in the world since then. And because of that, I did X, Y, Z. You know that the practice guideline exists, you know why you deviated from it, and you have sound rationale to back you up for it. Your rationale cannot be, I saw my preceptor do it. Your rationale cannot be, that's the way my the rules are in the hospital. It can't be like, somebody told me that this was the way to treat X, Y, Z. You need to know those things for yourself so that you can protect yourself. Like, this is one of those spaces where knowledge is power. Even if the knowledge isn't accurate, know why it's not accurate. Know why it's not appropriate. Know why it doesn't apply to this situation. And why you made X, Y, Z decision, because that will be what protects you if you're in a position to have to defend a decision that you made.
And as a legal nurse reviewing that case, if I go for a deposition, they're going to ask for my sources to support my position, either for or against what happened in practice. And they want to know what a typical nurse practitioner would do within that state, within their laws. Is this standard of practice, right? And so what am I going to go to? I'm going to go to the state laws, and I'm going to go to the practice guidelines, which, carry across this, country. Those are the sources that I'm going to use to consult and support my position for if this nurse operated within the standard of care or not.
More questions? We've terrified everybody.
To quickly say, sometimes when you go to a place like you're working for Indian Health Service or the VA, you can use a license from a different state than where you're working. You just want to make sure, be very careful, because there are state guidelines, and although you're allowed to do certain things and work under that other license, you just want to make sure you're not outside of those practice guidelines that you're talking about, the state laws. And so if you're going to stay, like I decided to stay in Nevada, I got a Nevada license, and there was a lot of other requirements for certain medications, controlled substances. I had to go through the board of pharmacy. So you have to understand all of those requirements to make sure that you don't find yourself outside of the lines in that regard.
I've also seen some providers put their reference as to why they're doing certain things. So if it is something that may not be in a clinical practice guideline, but is part of evidence-based research, then they'll put that in their clinical note. So that's one thing that you could do in terms of covering you. And then I don't know if you guys are going to get to this in terms of onboarding, because were you guys going to talk about onboarding in terms of the negotiations? Okay.
Yep.
Because I had something to add to that, but I'll leave.
I think there's a question in the front and a question on the side, or a couple questions here.
I just wanted to speak to what Dr. Brown was saying about how they cast a wide net and how people can decide to sue and name you for anything. I was just a floor nurse working an 11 to 7 shift, night shift, and I did sleep charting. And 3 days later, the doctor had discharged this person, and they completed murder-suicide after. And they just named everybody in the chart. I had charted they had slept, 3 days earlier, and my name was in the lawsuit. And it actually, I was flagged because I was trying to get privileges to do assessments at another hospital, and actually stopped because my name was flagged in this lawsuit because I did sleep charting. So I just wanted to speak to that. As far as liability insurance, don't wait till you're a nurse practitioner. Get it now.
There's another question up front here.
Hi, Jessica McCullough. Comment and then question. I would say that in one of my contracts, it was actually in there that if there was a discrepancy in the practice as far as decision making, because I had a patient complain about treatment, that it would be discussed between the collaborating physician, because I'm in Ohio, we have to have collaborators. And then if the decision couldn't be made, then you would go to the, standard practice. And so it came up that there was an older physician who retired, and there was a patient who was getting benzos and then stimulants, and he was taking them, a benzo in the morning, stimulant in the afternoon, or other way, benzo, just alternating through the day. And I'm like, okay, this isn't right. And it was one of the reasons why I actually left the practice, because she was like, just, give him what he was like, no, this isn't right. So definitely, like you said, know what you're comfortable with, and you gotta know. But my question goes back to the first session. We were talking about just the policies and making change and being a large group of nurses, and when we come together, what organizations are you guys a part of, like state organizations and national organizations? When I was at, I did go to the AANP conference here in DC, I think it was a couple of years ago, and they got together and each state came and represented, and they were full practice on how they actually got full practice and what they did, who they talked to, like everything, almost like giving all the secrets so other states could. And OAPN, which is Ohio State, they, came back and implemented a lot of that. And for the last 3 years, we've been pushing for independent practice, but everybody who's been listed on the opposing side have been all medical associations, and the other side is like all insurance companies, all, type of other places. But being involved in those organizations did open my eyes to policy lobbying and how to be involved. So just wanted to know how they made a difference in your actual practice, like in getting more involved.
So some of the additional sites that we have up here on the board, so the Center for Health Connected Policy is a great resource for all things telehealth and remote services and laws and regulations and updates and things like that. These other sites are more psych-specific organizations, so the American Psychiatric Nurses Association, International Society of Psychiatric Mental Health Nurses, American Association for Nurse Practitioners, and of course, as we are all members of our American Nurses Association, and be active in your state chapters of American Nurses Association. And then even within your state, there are likely state chapters of nurse practitioner organizations. You just have to find them. And one of the ways that we find them in different states is a lot of times when there's problems, right? Like in Delaware, when they tried to cut our reimbursement by 15%, a whole bunch of nurse practitioners from all over, all different fields, all different specialties came together and said, absolutely not. And so then there's like a coalition of NPs, and there's, in upper state and like lower state, because just it's a bigger state where it's hard to get to meetings if they're 2 hours away. So there's ways that people can come together with like a mutual goal, a mutual purpose to move forward. Sometimes getting people to agree on what that goal is can be a challenge in the beginning, but it's something to work towards. So these are just some of the organizations. I think there was a question over there.
Yeah. So I just wanted to first say thank you for having this, because as you and I talked about yesterday, a lot of times at these bigwig institutions, you would think that they give you this type of information, and they don't, and you never know what you need until you are actually ordered. And so I was just about to pay for my DEA license, remember yesterday, and everyone was slow down, because having been licensed for the past 2 months in New York, I'm feeling pressure from where I just recently got a clinical practice job, but they also didn't, detail a lot of these things. So my advice to everyone, I know you're in transition, many of you, because we're all in different phases, but slow down and connect with people, because you could go down a foxhole is what I call it, and, you know, it could be a long way down and a hard fall. So this is really good information, and it saved me $888.
Doing the work, right? Yes, doing the good work here.
And a lot of times, most of your employers don't know what steps we have to take.
Yes.
You're the one telling them.
Yeah.
They don't know. They deal with PAs, MDs, MPs. They have no idea. So a lot of times they'll say, "Oh, you need a supervisor." No, I don't. You know, like you have to tell them and guide them.
And sometimes you have no control over the process. You have no control over how long it's going to take the state board to process your application. And you may have this employer saying like, but we needed you to start yesterday. I understand that. I had zero control over this part of that process, right? So the best thing that you can do for yourself is don't be the reason for the holdup, right? Don't be the reason that something isn't moving forward. Do what you can. Read the application thoroughly. Submit the pieces that are required. And the rest of it, there is nothing that you can do in terms of how long it takes to process it. When you are interviewing, we didn't necessarily go through it, but I would just kind of put it out there. Think about how you are presenting when you are interviewing. One of the things that I used to have my students do was develop a portfolio. And in that portfolio, when they went to their interview, they had a sample of a full psychiatric evaluation. They had a sample of a progress note that they would have written, so that you can present to the person that you're meeting with, this is an example of how I work, how I would write, how I would document a chart. There's my rationale for my decision making, for whatever med recommendation that I made, and and they're leaving that with them, because that's something they have concrete that they can look at and say, oh, this person knows what they're doing. So I'm less concerned that we're going to bring this person in and we're going to have a hard time, or we're going to have to teach them a lot. Other things that I would suggest when you're interviewing, some of you might not be happy with me about this, but take a look at your social media profile. Like, look at your pages, look at what's up there. Look at what's up there and out and available to the public. Not telling you not to have your fun, not telling you not to wear whatever it is that you want to wear, but know that your employer and your future patients, clients, are going to be looking you up, right? Like, people have a social media presence. And if you try to tell them that you don't and they find out that you do, you've lied and you're out. It's not like, and it's not about saying like, don't post anything political or any of that stuff like that. Like, that's not what I'm saying, but you need to know like what's out there, what somebody's gonna look at when they see you, and is it going to say, we want that person representing our company? If there is something that you would feel awkward being called into an interview and being asked to explain like why this looks like this, you probably want to take it down, right? If you're interviewing for a drug and alcohol program and you're in your like whatever and drinking, and you're like, hey, I was like, have your fun, but maybe don't post it,
keep
right?
it discreet.
Like, keep that stuff to yourself, because like you become someone, like your role is different, and like I said, patients are gonna look you up, clients are gonna look you up. You're seeing children and adolescents, their parents are gonna look you up and say, like, do I want this person treating my child, right? Like, these are things that you need to think about. When we're talking, yes, oh, I'm sorry, yes, Dr. Gare.
Thank you.
Yes, ma'am.
I just wanted to reiterate a conversation, a comment I heard you and others make. I want to share a vignette with you. I was the advisor for students some years ago. Dr. Ronde served on her committee as well. She was a pulmonary specialist, and she was very argumentative about everything. So I suggested she go to law school. She went to law school and she became an attorney, and her specialty became malpractice. I guess about 2 or 3 years into the practice, she got a case of a person who was in an acute care unit and the person died. She went through the chart and found that there was no documentation of the Y tube, the trach Y tube being cleaned. She didn't find it. She asked that every nurse who ever cared for that patient take the stand, and the physicians. She won the case and got a huge settlement of money. Now there was no documentation, and she won it on the basis of no documentation. So I know we get in a hurry, and when we see patients, there are a lot of issues we have to address. But my message to you is never be in such a hurry that you can't do what our colleague just said. Clear, well-written documentation, because you're providing service, quality service to the patient, but you're also protecting yourself and your license and your livelihood. The second thing, it's a lot of discussion about private practice. That's fine. This is about the second wave of nurses going into private practice. Clinical nurse specialists did that back in the 70s. Some of the same issues then, same issues now. What I want to suggest to you, that you get a mentor in the practice where you are, and get a mentor who is not in the practice, because the conversations will be different. And you need to give quality care, and you need to protect your license, your reputation, and yourself. Thank you.
Yes, ma'am. I know that we have a question over this way, but as we're moving the microphone over that way to that question, I would just make a point about electronic health records. So they make things, they're supposed to, right? Make things easier, right? You click and it writes a sentence for you, and then like you can finish a note in less than 2 minutes. When you get audited by insurances and they read your notes and they look at them and they're like, how do I know that this note belongs to this patient versus anybody else? So don't like get so wrapped up in they have a great EHR. I can just click right through and my note can be done in 3 minutes. Like that's the way the EHR companies will market to you. Your note can be done in 3 minutes. Did you document about that patient specifically, or did you just click like complex patient came in, anxiety is improved, depression is not, depression is level 6 or where it used to be an 8, and review of systems, everything's normal, note is done. What patient is that referring to? And all we did was click. So when they decide that they don't want to pay for something and they want to pull an audit and they want to review your notes to make sure that you documented everything appropriately to justify the level of care that you're providing, if you just clicked through, it's not going to help you. So take a moment, be specific to the patient that you're talking about. There's a question over here. Yes.
Hi, good morning, everyone. My name is Edward Oladipo. I'm from New Jersey. I recently finished my program. I'm already working for an outpatient psych facility. I just want to piggyback on the social media stuff and share my experience of what happened to me. So, as we all know, or probably most of us that are working with an outpatient services, they are very fast paced and they are all about profit already. So they want you to see certain amount of patient within an hour. So the more patients you see, the more, they get their reimbursement and money. So new graduate, looking for job, I just wanted to fill in, so I joined them. So when I look at what they are doing, most of their patients, they were just giving out benzos. They don't really dig in and, they'll tell you the process. You have to order UDS, you have to order EKG, do this and that. But when I was reading the notes of previous providers, I realized they are not doing that. So this is what happened to me. So when I started working with them, so I was slowing down the pace a little bit. So if you are on multiple benzos, that's not going to be a problem for me to prescribe. I'm not going to give you more than 15 days prescription. That is one. The number two is I want a UDS. So I want to know if you are using some other prescribed medication, or if you're actually using what I prescribed, so I will be able to see that. So I have this particular patient. I'm coming to the social media stuff that you just mentioned. So this patient is on multiple benzos, and I was like, you know what? I look at the record. There is a way you can see when they last filled their prescription. So I use that PMP, to manage it and look at it. And I find out that this guy is going from one provider to another, changing pharmacy, So I said, well, unfortunately, we have the same name. I said, no problem. I'll give you 15 days. And I want you UDS. When you come back in 15 days, if I'm satisfied with the result, I will put you back on the 90 days. They usually give you 90 days everywhere he goes.
Whoa.
This guy was so riled up over the teleservice. He was so like, no, you can do it. I was like, no, I'm the one writing it, and this is what I'm going to do. He said, okay, no problem. Send the 15 days to the pharmacy. I was at work. I came home 9 o'clock at night, and my kids told me, they said somebody came and was asking, like, is this where Edward lives? Where's Edward? And I was trying to, like, can they describe it? So they described the patient. I've seen a lot of patients within that short space of time, so I couldn't really figure it out. So I go back to my phone. The same time he was in my house, he called my phone. So I look at that number, I called the number, I said, did you come to my house? Who is this? He said, oh, you are my doctor. Blah, blah, blah. He said, you're trying to stop my medication. And you know what? I'm going to do something to you. I said, what are you going to do? Do you want me to call the police? He said, well, it's up to you. So I called my supervisor right away. And they were like, what? So I was looking around and I was like, how did this guy find out where I lived? Guess what? He went on social media looking for me. And, a lot of stuff happened when we were young. We signed up for Facebook, Instagram, Snapchat, and we try to catch up with these young folks. Like, everybody's doing everything. Like, you know what? I'm going to be over there too. So there's some stuff I've put on social media that I didn't even remember. So this guy was able to find. I even realized that he has even sent a friend request to me on LinkedIn. And I've accepted him. And I didn't know. So I went back and I saw his name. I was like, what? So I called the cops. They came. So when I called 911, I was like, I'm not sure if this is the right place to call, but this is what is going on. The lady was like, that was an emergency. We're going to send an officer over. The police came. They gave me the name based on the phone number. They said, are you familiar with this name? I said, I've seen a lot of patients. I can't remember. So I went back upstairs, put it in my, border, and then I was like, oh, it's this guy. The last few years he did came back positive for marijuana, fentanyl, cocaine, and stuff like that. But the provider that I've been seeing him prior to the time I saw him, they just keep renewing 90 days. 90 days. I changing pharmacy, changing provider. So I told my supervisor, I said, you know what, take this guy off my caseload. I'm not going to be able to. And they play a lot of games too because they are only in for the money. So they say, oh, we're going to find another provider for him. But the question is, until we find a different provider for him, we're obligated to, continue renewing his medication. I said, okay. So the first time I renewed, the first 15 days. So after 15 days, they sent me a message again and said, we couldn't find a provider for him. Can you renew for another 2 weeks? So I wrote an email. I said, I will renew one more time. That's 30 days. And after this, if he needs to be seen, he needs to come physically to the office. I have to see him. That's one. I need a UDS. And I want to have a meeting with the supervisor, with the collaborating physician, and everybody. We have to discuss this guy's case. I said, this is fentanyl, this is CSC, this is cocaine. If something happened to this guy, I'm the last prescriber. They're going to come after me. I just came out of school. I have student loan to pay. What's going to happen to me? So, and that's what is going on. So a lot of us that are just coming out of school, we don't know these things. And those employers, mostly the outpatient services, they are very quick because they are in for the money. So we have to see, for my place, we have to see 4 patients in an hour. That's every 15 minutes for follow-up. For initial visit, it's 30 minutes. But what can you do in those times? How much can you do? And everywhere you go, those employers will say, we need experience. And how will I get the experience if nobody is ready to hire me, from out of school?
Yep.
So I'm just sharing this. So if you have social media account, I'm on every social media. So you have to go back, remove those pictures. Some pictures we took when we went on vacation. We are in the club dancing. We are drunk. All the stuff. Everybody, we were young, so we are just catching life. So if you want to go back and just and find all your social media and try, and if you have your addresses up on social media, I think you should remove it. Because when you become a nurse practitioner, you become a public service individual, they can easily find it. These guys send a friend request to me on LinkedIn. That is how much they go. So the police went to his house and they talked to him. He was always trying to take away my medications, stuff like that. So they said, well, it's up to you. He said, right now, the way things are, we cannot do anything. So if you want to press charges, it's up to you. So you can come to the courthouse the following day, we're going to give you the police report, and then you can file a charge, and then we can put a restriction on him in certain radios. He cannot contact him. I said, you know what? At this point, I'm not going to file any charges. I'm about to move out of that community anyway. But the question is, they can find you. So we have to be really careful. Thank you.
So many issues brought up. And I'm going to try to address a couple of them. One is when we talk about negotiating contracts, you can negotiate how much time you require to do your job, right? And so you can say, I need an hour, I need 90 minutes for an initial eval. And you can block out that time for yourself. It's part of the negotiating process. You might say that you need 30 minutes or 45 minutes for a follow-up. And that is okay to do, and it's absolutely appropriate to do, particularly when you're a new grad, right? You need more time. And so I want to put that out there that you actually can negotiate the time of your appointments as part of your practice when you are going into a practice. So I want to say that. I also want to address that you're going to have some choices to make, particularly around prescribing benzos to patients. There's lots of incorrect practice that is not according to practice guidelines that's going on, and you are going to be inheriting those patients. And if you are going to practice the way that you should be practicing, which means perhaps short-term use of benzos, if at all, along with the combination of a long-term plan for that patient, which is not a benzo, you're going to have people that are absolutely upset with you. They're going to come after you. They're going to complain. They are going to write awful reviews. And you're going to be put in a position of a lot of pressure. Do you give in to that pressure and begin to prescribe the way some other folks are prescribing? Or do you do what you're supposed to do in that situation, despite the complaints, the nastiness, the aggression, and everything else that's going to come with the territory of doing what you're supposed to do when it comes to those prescriptions? And it's I think what you described is a very difficult and challenging position that nurse practitioners are put in when it comes to doing what you're supposed to do in terms of the prescription of benzos. It's out of control, and it's been out of control for a long time.
There's a question there.
Gentlemen, I'm sorry I stepped out, but he had mentioned like our loans, which are a big thing for us. Have you guys experienced working for an institution and they present you with a contract to help you repay your loans, or any other experience as far as loan repayment? I mean, I know there's a number of them out there, but especially when it comes to organizations that you're going to work for, it's like, oh, I'm going to give you this dollar amount if you work for us for this amount of time. Had you experienced that, and what might have been the pros and cons of that?
My first job was at the inpatient psychiatric unit. Originally, I'm a family nurse practitioner. I went to the hospital and I told them, I was like, you need an NP in the psychiatric unit. And they were like, all right, well, you be the first one and you start this out. And I negotiated with them, well, I need to go back to school. And I want you to pay for my certification. And they did. And they didn't put any restrictions on it. So I worked there for 2 years and I left. But a lot of times, nothing's free, right? So the amount of work that I put in to help them develop that role, I guess offset my certification. But always be aware, what do they want from you?
So just going back to the onboarding piece, so I'm working in pediatric primary care with a behavioral health focus, but I requested that I only see a certain amount of patients up until a certain point so that I could get familiar with the institution, the new EHR. So that is something that you can definitely negotiate. I also requested to have a collegial mentor that I met with once a week because I was transitioning. So part of it is I was transitioning from specialty care, pediatric endocrinology, to primary care. So I needed to kind of get up to speed with some things, and I wanted to make sure that I had somebody that I could just collaborate with as I was making that transition. That's something that you say you have to know yourself. I know myself and how I want to practice and the quality that I want to provide. And so that was something that I thought was really important. And then in terms of the student loan forgiveness, when I was working at Children's Hospital Philadelphia, I had been in the Bay Area, and Children's Hospital Philadelphia was supposed to be one of those institutions where you could get loan forgiveness. But when I got hired, they had ended that program. And so I had told them that I wasn't going to come. But then a month or two later, they came back offering the job again and saying that they would offset my loans a little bit. So they did give me a little bit of money, but then I didn't realize it was going to be taxed. So just consider that. If they are going to give you some money, make sure if they say 10,000, 20,000, 30,000 that you get the full, right? So they need to add on some to make sure that you get that full amount. But they did make a stipulation that I was going to work there for a certain amount of time, which it was a little bit more time than I should have been there. But so just keep that in mind. And then there are other programs too. So there are the national programs, but like in Oregon, there's a state program that actually was far exceeded, in my opinion, the national program, because one, it wasn't taxed, two, it was more money. So just consider, and that was something I didn't realize until I applied for this specific job. So just maybe look into that.
I just want to add, for those of you that are interested in doing research, I have the NIH loan repayment program, and so doing 40% of research, they will repay your loans back up to $50,000 for the 2-year period, and they do also pay the taxes for that, so you're not being taxed on it.
And then what about faculty? Isn't there a faculty loan?
There is a nurse faculty loan repayment program as well.
I just want to jump in right quick. Just going back to the negotiating as far as patients and things like that. So if you are going to be salaried, make sure that you understand or get however many patients they expect for you to see either on a daily basis or a monthly basis. If you meet that quota, do you get extra money for the extra patients that you see within that month, and how much of that money is actually going to go to you? So whenever you go speak with them, try to get how much they're actually expecting you to see. And of course, like if you are actually able to meet with a mentor or a collaborating physician someone who's actually willing to mentor you, of course, do that. But just don't let them take advantage of you just because you're salary.
Yeah, and the question becomes, what is your salary based upon, right? What's your percentage? And what is that being calculated off of? Is it being calculated off of the billable, the receivable? What happens when somebody doesn't show up and there is no bill? So these are all the things that you need to consider in terms of how your salary is being calculated. It's just not going to be this number. There's a calculation that goes into that number, and then there's some expectations that go into that as well. So these are all the things that you need to be considering when you say yes to whatever figure it is. You need to know how that's being calculated. And it's different for each practice and each setting that you're going into.
So you may have this wonderful interview and it may be great and you feel like it's going to be a fantastic environment for you to grow and thrive. But if you don't ask those kinds of questions, then when you get your paycheck, you may say, well, wait a minute, what happened here? So you have to make sure that you have base pay and that, if you have a bunch of no-shows, that you're still going to get a paycheck. RVUs, you have to understand, how if there's based on productivity. And so in this time, so there should be, you should also keep track of your panel. So during the onboarding process, when they're asking, well, before the onboarding process, so the interviewing, when you're having this interview and they say, well, do you have any questions? So some of these things you want to be asking about. You also want to ask about the benzos. What is the clinic's view and in terms of controlled substances and what protocols do you have in place? And then when you're starting, what does a day look like? If you have an opportunity to shadow and visit. Let them pay for you to come out for a week and if you have that time and allow them to take you to dinner and enjoy yourself, but also have these questions answered. I was able to negotiate onboarding time and only see 2 patients per day, and then get for intakes, only have a set number of intakes that I took per day. So people are like, how did you do that? What would you? Because I just asked for it. You have to ask, and sometimes they will say no, they're not going to do it. But if you don't ask, then you don't get that. So, and then also don't tell everybody your business once you get your contract. There are some things like I got them to agree to pay for certain things that I guess were not included in other people's contracts. But I don't go talking about it amongst the folks that you work with because that can cause other problems too. But if you can help somebody as you're leaving out, hey, next time you have this, try to ask for this or that because they will include it. And then another thing I think that has helped is just like you were talking, Eniel was talking about the loan repayment, the state. So pick your state. Look at who is paying. Nevada is paying $50,000 for loan repayment. So you go by state, get those local. Oregon pays
up to $105,000 for 3 years. $105,000 for 3 years.
That's Oregon.
And sometimes they'll renew for a certain amount. So you may get 90, and then the next 3 years you get, the.
Oregon fell through. That was my first choice. I was leaving Washington. I was going to go to Oregon. But yeah, just look into all those things because their opportunity are out there. I see 5 patients per day. That's what's required. I see more than that, but that's what's required. So technically, I'm only required to see 22 people per week.
Wow.
Per week. When I was at Multicare in Washington State, I saw 18 people per day.
Right.
That's a huge difference. So just.
And all of this stuff that we're talking about in terms of negotiating and onboarding and thinking about your patient load and all that stuff like that, those are all things, guys, there's some chatter that's making it hard to focus. So if we could kind of bring that down a little bit, thank you. What I would say is that as we were thinking about all of these things that we're talking about in negotiating your first job, also think about it when you're thinking about, can I transition to my own practice, right? Because a lot of people ask it, like, when can I do my own practice? Am I ready to start my private practice? Like, at what point? Some of the things that you have to take into consideration is how much money do you have up front, like capital-wise, to get started? Do you have a place to see people? Do you have a lawyer to look at your paperwork? Do you have an accountant to plan your finances? Can you go for a couple of months not getting paid while insurance panels you, right? Because when you submit a claim, most insurances have 30 days to decide whether or not they're going to pay or deny that claim. And if they deny it and send it back to you because you have to fix it for whatever reason, and then you have to resubmit it, okay, they've got another 30 days. How many months are we getting to before you're actually seeing the money. How much money are you spending when you're paying a billing company to submit claims for you and to follow up on denials and all that stuff like that in order to get your money? And if you're gonna opt not to deal with insurance, which some people do, are you in an area where people have enough money to pay to come see you? And if they have the money to come see you, what expectation will they have because they're paying to come see you? So I paid for this appointment. You will write what I asked you for, or what I'm telling you to write, right? Because they're paying cash, so it becomes something different. If you're using private insurance and they have a deductible that they have to meet, so you want to see them, but now you have to send them a bill in order to get the amount of money that you're supposed to get. These are all things that go into the consideration. Like, yes, I'm not trying to dissuade anybody from having a private practice, but understand that it is every day, all the time. Insurance companies require you to have somebody to have access to you 24/7, and that answer cannot be call 911 or go to the ER. I have to pay for a call service so that they can page me in the middle of the night if somebody needs to reach me for me to tell them to go to the ER. But they have to be able to speak to a live person. A recording is not going to be sufficient. So even though it's all this stuff, it's all my stuff. It's all Dr. Lara's stuff. When it was Dr. Brown's, it was all Don's stuff. So it's like, yes, I'm working this hard, but I'm working this hard for myself and my family. And when I look at like things like safety and all that stuff, like you don't want to see the way I'm like. Maybe you do want to see it, but
I think they do.
I'm just saying. Like when I think about people, being upset, right? That they might not get benzos for me. They know that they're not going to get benzos for me, but like that they might not get them, or they're going to get them for a short period of time, or I'm going to take something away from them. My conversations are respectful. I'm not just like, no, I'm not giving this to you. So that goes a long way, right? Being respectful in communication. But
educating,
right? Like this is the reason why I'm not going to do X, Y, Z, or this is the reason why. It's more for your health and for your safety. It's not just because I don't want to give you something. And I'm sorry that the person you worked with before created a situation where you became physically dependent. But this is what we have to work with. And it's okay for you to say that because you are practicing within the correct practice guidelines. They're going to be mad. People are going to be mad when you tell them no. Like, of course they are. But when they know that you're making a decision for their interests, health, and safety, and not just because you want to be a jerk and withhold stuff from them, like, they can process it a little bit better. But when we were talking about physiological safety, part of the reason that I dress the way I dress is because I have stuff in all of my pockets. No, I am serious. Like, if I need to grab something to do something, I have stuff in practically. But I dress the way, like, if I need to go, if I need to run, if I need to do whatever, I'm able to do that. I'm not gonna trip over my shoes. Like, the penknife in my pocket is a legit penknife in my pocket. It's a pen. It's a knife. But that's in my pocket. I practice martial arts because I'm like this big, right? Like if somebody wanted to, and I've had people tell me like, I could hit you. I'm like, you could. I don't recommend it. but I know that I can defend myself. I know that I can protect myself. Should I have to? But I also know when I'm around somebody, I can judge how far to stand from them so that they can't reach me if they put their arm out. And if they were trying to reach me, I have enough room to back up, to get away from them. I wear a belt. I don't need to wear a belt. Like, look at me. But I need to keep somebody away from me, I can. If I need a tourniquet because somebody did something, I have one. If I needed to restrain somebody, which I never want to have to do, but if I ever had to, I could. Those are the things that I do. The necklace I wear around my neck. You won't see it. Be glad that you won't see it, but if I need it, I have it. Those things are things that I do not because I want to go fight and beat people up. That's not what I'm here for. Like, I'm here to, but I'm also not here to get hurt by anybody. And having some protection, not even just like having stuff, because it's not enough to have stuff and not know how to use it. That's more dangerous for you, right? Like, if you have stuff on you and you think you're going to protect yourself, like having a concealed carrier or a baton or whatever, any of that stuff that you're carrying around to like protect you, if you don't know how to use it, it'll be, they take it from you and use it against you. So make sure that you understand what you're doing and put yourself in safe positions. How do we set up rooms when we're in with patients?
The closest to the door.
Yes.
Yeah, no patient between you and the door.
That's right.
No one behind you, right? Even like sitting behind a desk. If I'm behind a desk, I've got something blocking me from the door, right? Like I can't get out. So my desk is like this and a patient is back there. So like if they want to flip out, that's fine. I can step out and they can stay in there and have their like have your moment and I'll come back in when you're done. So like those things to help prepare you, like the more that you know, especially about how to protect yourself and how to be safe, the calmer and more confident you'll be in the situation, right? Like if somebody is maybe getting a bit riled up and all that stuff like that, like being able to keep yourself calm and grounded, either because you know good breathing techniques or you can touch that pressure point in between in the web, that can help calm you down and keep you stable and keep your tone level and even. What's my face, Nina? No, not the resting, not the resting, not the resting.
Emotionless.
Right. So you guys see
Poker face.
right? Like you guys see a different side of me because I'm able to be more like, but like anybody else, they get one face. No matter what they're saying, this happened, that happened. I can express that's awful, that's sad, that's hard, but like I don't change. And the reason I don't change is because they need to have their space. Patients need to have their space. Like if I'm like, oh my goodness, and all that stuff like that, or if they tell me something horrible and traumatic and I react on it, like then they worry that they've traumatized me in some way. So I've got to be able to keep myself level and calm and steady so that they can have whatever it is that they're having and it can bounce off of me. But how do we do that? Like how do you guys manage doing that?
As far as what, safety?
Yeah, well, not just safety, but like keeping yourself calm, especially when people are not so calm when they're mad about not getting what they want.
Oh, I'm really good about setting boundaries. That's the one thing, and that's why I went into private practice, because I'm able to develop my own policies. I develop my own culture. Patients know when they come in my office what's expected, what they're not going to get. We have this discussion at our initial visit, and they get the paperwork before they see me. But I also want them to feel safe and be able to express themselves. I think you have to, in order to set boundaries, you have to be that way. Mm-hmm. They have to know what they're going to get and be direct.
Yeah, so for me, I mean, if you remember, I'm pretty much a laid back person. I don't really change wherever I go. However, I do think it is important to set boundaries, especially where I work at now in substance abuse, where people are wanting extra this and extra that. So sometimes you do have to be a little firm. It's like, hey, I cannot give you this, but we can do this instead. If you don't want either one of them, then, oh well, what do you want me to do? But as far as being safe and the practice and things like that, I always sit by the door, like directly by the door when I go in. So in case there is an issue, I can immediately step out And granted, I'm 6'4", so not many people are trying to, attack me. But, since we're in sight, they don't care. It's just whatever. But there are also people around. I'll make sure I know who's around me as far as staff if I need to get out or if anything happens, just because you never want to be in a situation where you're somewhere alone and nobody knows where you are, because that's a lot of times how things happen to nurses.
I want to also add, in terms of, we were talking about this earlier, this is hard work. And you also have choice over your patient population. And so again, you have to know yourself and know your own history. We don't come to this work with a clean slate. We have our own backgrounds and traumas and adversities that we have experienced, right? And so you have to know which patient population is going to be best for you and be aware of transference and countertransference. And is it going to bring something up for you or not, and how you're going to deal with that, and how you're going to take care of yourself. So a lot of the work that I've done, we were talking about, vicarious trauma and secondary trauma. How are hearing some of the things that you're going to hear in your practice going to impact you, and how are you going to deal with that? And so for me, I'm able to compartmentalize very well and remove myself in terms of, this is not something that I'm going through, even though I'm hearing it. I'm able to do that pretty well. And so unfortunately, I have like a bad memory when it comes to names and things like that. But I think part of it is because that's my ability to put my patients and my work over here in my brain and access it when I need to access it, but it's not something that I'm necessarily carrying around with me all of the time. And so that's how I'm protecting myself psychologically. So you have to be aware of the impact and what patient population you're going to encounter and how that's going to impact you as an individual. And what are you going to do to take care of yourself mentally as part of that work?
I would also say, just one more thing. I would just also say that it's okay, like if you need a therapist, just to unload.
Amen.
Some of that extra information. You can't exactly go home and speak to your wife or your husband about the day you had about this patient and what they told you, just because of HIPAA and things like that. But if you have a therapist, you're just able to vent a little bit more. That actually helps a lot. Like I have a therapist that I speak to, and he helps me a lot when I'm going through issues. So I want, you all know it's okay to have a therapist if you need to speak to about your job or whatever you're going through, because you still take that stuff with you, like Dr. Bowers was saying, whenever you go into practice. And so you may not think you notice it, but subconsciously you're still processing that information, even though you're not necessarily thinking about it.
Yeah. And that's part of our job. We need a therapist to do what we do.
Yep.
Just like liability insurance, we need a therapist. Someone
It builds our empathy too, right? Because imagine you have a patient that is coming to you and laying their life out on the line, and you're expecting them to do that and be honest, right? It'd be a bit hypocritical if you were not going to follow the advice that you would give your own patients and say like, hey, maybe you should talk to someone, right? And get some help. I tell everybody should have a therapist, because everybody needs somebody outside of their life that has nothing to do with it, that they're able to bounce it and talk things through. When you have a friend, there's supposed to be reciprocity. They're supposed to say something, you're supposed to care, and then you say something and they're supposed to care, right? And it's supposed to be like a give and take thing. But when you go to a therapist, it's like the time where it actually gets to be all about you. You create that space for other people. Have that space for yourself. When else will it get to be all about you? And we barely make anything all about us. So take advantage of that opportunity, and by putting yourself in that position of vulnerability, you'll understand more what it's like for your patients to have to be in that position to talk about some of the stuff that they're experiencing or that they've gone through or whatever. And it's not for you to go and sit and be like, oh yeah, that happened to me too. Oh, it's not about you, in that time. But it's to understand what it feels like to be in that space, to need help, and to get help.
Can I just?
We have about 15 minutes left, so I'd like to prioritize any questions that people have for the panelists while we have them up.
Hi, I just want to say it was a great segue because I am a nurse therapist. I see nurses, but I was really going to tie into what you were saying about the benzos. Having had an 86-year-old client who had chronic pain and she was prescribed medical marijuana, and I know you can get recreational marijuana in a lot of states now, but she described her traumatic experience of deciding she was going to try medical marijuana and took gummies or whatever and was out for hours. And if it wasn't for her husband finding her, she don't know if she would have made it. So I think it would be wonderful if there was also training on how, as practicing providers, mental health providers, as to how we're going to handle something that is recreational now and people can access, but there's real no regulation on how much or whatever that a person's going to take.
If I could add something to that on that medical marijuana, because it is going to be something that you will see in practice, especially your adolescent patient. Be specific. If you ask them, do you smoke? They're probably not gonna say yes. Use all the street language, weed, whatever. And to add to that, for clinical, if you need something that will help you, we did a presentation on what NPs need to know for medical marijuana and your CYP4 enzyme, isoenzyme pathways. I and Dr. Newton did a presentation this year at iSpend. There's a lot of, I can share the documents with you, but there's a particular page that is very, very, like you can just copy, paste, wherever you can have it close by when you ask your patient if they're taking marijuana, what is it impacting, what pathway is it inducing, or what pathway is it inhibiting. I'm not a specialist in that. I was just called in for the little piece of it, but I have that material if you need it.
I also ask about strands and types that they prefer. And the reason I do that is not so much for that, but I mean, you could go online and you can look up the different strands. And for me, it is information about what they're really self-medicating, right? It gives me an understanding of the symptoms that they're experiencing and why they are choosing that specific strand. So for me, it's data, which is why I ask them very specifically what they prefer.
One thing I wanted to add in terms of the safety conversation is I work for a federally qualified health center, so we have 6 different clinics, and I'm transitioning to the school-based health center. And one thing that really struck me was I didn't really feel as safe at that place as I did at my other clinic. So my primary clinic is a swipe in, swipe out. There's also a front office, and there's several different exits. At the school-based health center, there's one way in and one way out. And that just did not make me feel safe. So we started looking at other possibilities, but one of the things that came up was our organization offers a safety assessment of where you're working. So we're looking at the windows, we're looking at the locks, we're looking at the swipe in, swipe out, and obviously being in a school on the grounds, you obviously have to think about school shootings and stuff like that. So just something to consider if you guys are working at a place where you don't feel safe and they do have that option, maybe just review what the safety assessment is and have them do the safe shooter training as well. Also, we have a school resource officer at the high school, so they also provide a different type of safety assessment. So we're gonna be doing that when I get back, but just something to think about for those who may be going into that. So the panel did speak to safety and understanding, how to protect yourself as well. So I work in sundown town, and for folks who don't know what a sundown town is, basically when the sun goes down, people of color it's encouraged to be out of the town. You need to be gone. There's a whistle that goes off to let you know that you're getting close to that time. So I work with Native Americans, indigenous people that live in northern Nevada. My question, so I've learned how to take care of myself, and I am out of the town by that time. But also I don't go the same route to go home. I do not post And still people can find you, but I do not post certain things, and all of that. But my question is, how do you teach your team how to make those, because I watch people when people are walking into the building, they don't seem aware of what's happening or what's going on, and you need to be scoping around. You don't need to be walking around and people can be behind you, or you're heading around the corner of the building. Don't just walk around the building. You need to see what's on the other side and things like that. I mean, those are things that I already knew, and so I practice them. It's unconscious movement, but how do you teach your team to just be more aware of what's happening? Because that's how bad things happen, when people aren't aware of what's going on.
Well, as a practice owner, that's one of the things we have to look at. Like when I purchased the building I practice in, put cameras all around. I put a window, broke a wall, we put a window. People will come in there and they're like, "Did you work an inpatient?" Yep. Because it's like we have to protect our staff, and I want them to know that. When you come here, we have panic buttons, we have a computerized communication between offices. And these are things as nurse practitioners that we have to implement. Sometimes we're working for other people, social workers, non-clinicians, that don't know this. And we have to speak up. Not only that, so we have to verbalize this to our staff, but also our family. I have 3 sons. My son's in high school. I take care of a lot of his peers. I have to have these conversations with my kids. They know exactly what I do. They know that if we're at a store and someone comes up to me, they know. They just walk away. My older sons will grab my younger son, they walk away, and they don't say anything. Like, I've already programmed them to be that way. My house, cameras, same thing. You have to not only protect yourself, number one is my family. Like, I do this to care for people, but when you do your job right, people don't like that. So
I just want to highlight the value of getting inpatient psych experience.
Oh yeah.
I'm just saying, like, that, I think that experience is what conditioned me as a nurse practitioner. The things that I learned working, I'll say on a good team, right? Because not all inpatient psych is created equally, but working with a good team in inpatient psych and actually finding people that you're gonna work with that might have that experience, I think is valuable.
If I could add, sorry.
Right, I actually was gonna step back a little bit from the safety part and just part of the licensure process. And when I listened to the brother's experience, I just wanted to remind us also, we have to get a national provider identifier number as part of that process. And I was advised, and I would also advise everyone here not to put your personal address on the national provider identifier, because all you gotta do is just put that name in and then and say NPI number, and it just comes up, and all your information is on that field on that site. So be careful what you put on, what address you put on there, what information you put on the application for the national provider identifier number.
virtual mailboxes, take advantage of that.
One last thing about the address, just also be sure whatever address you use for the DEA that it's an actual legit address. That way, if there's an issue, they don't come to your house while you're prescribing medication out of your house. You get in big trouble.
Yes. So it's connected to your job?
Yeah, so whatever job you actually work at, you could put that address as your DEA because that's where you're going to actually be prescribing medication. That's where you work at.
And you can always call. Yeah, you could always call and say, I work here as well. You have to report it to them.
And just know that that mail is going to come to that work address, so depending on the mail system. Yeah, just FYI.
My question was going to just speak to credentialing, which is insurance credentialing specifically. I know usually if you work for an organization, they'll just get your information and they'll do all the credentialing, but is that the process that you guys went through, or did you do your own credentialing? Did you pay someone to do your credentialing? Because, I mean, I know it's a process, it takes some time. And then did you negotiate any of the contracts with the insurance company as far as pay rate, or was it already like set? Because I know different states, different rules.
So all of those things are correct, but there's a things that you can do that will make the process easier, right? So CAQH is a place where you will, it's an acronym, we can bring it up during the lunch break, but CAQH is a place where you will build your clinician profile. You'll enter your licenses, you'll upload copies of your diplomas, your professional liability insurance, and all that stuff like that. You'll start building that profile. That is what most insurance companies are starting to access. So it's like a hub for your information. So a lot of insurance companies will just ask permissions to view your information. If you just grant blanket permission, anybody that you're getting credentialed with will be able to access and view it. Now, if you go work for somebody and they have to pay their credentialing department, look at my Dropbox, it's a mess. Not a mess, it's an organized, I have this license, this expiration date, they're looking for all your licenses, everything like that. And the easier that you can provide that to people, the faster, because sometimes credentialing can take up to 3 to 4 months. And then add COVID onto everything, and now they're it takes 6 to 9 months, whatever. They've got a backlog of people that they're trying to credential. You can negotiate. Now, if you're working for an organization, you may not be able to negotiate the rate because the rate is with the organization. It's not with you as the individual. If you're working in private practice and you're contracting with them, you may have some room to negotiate the rate that they're going to pay you. Some of it is state specific, where there's parity, where nurse practitioners and physicians get the same. Other states, there isn't. So that, again, is one of those things that you look into depending on where you're practicing, what state you're in, and all that stuff like that. Some places will charge you, if you're joining a practice group or something like that, they'll bill you because they're paying somebody to do your credentialing. And if you up and leave before a year is over, they have lost a lot of money on you between credentialing, professional liability insurance, all the stuff that they're paying for just to bring you on as a provider. If you leave before a year is up, they've lost a lot of money. So part of the reason that some of these contracts look the way that they look is because they are trying to protect their investment in bringing you on. But the more that you can do yourself, building your CAQH profile and stuff like that, the easier it is to get credentialed. And then should you happen to want to go do something on your own, you're already in these network systems, right? Because you already have a profile. They already did credential you. You're just changing locations and changing your tax ID and stuff like that. So then you're already a paneled person. So that is a way that it makes it easier to transition to being credentialed on your own. Some places will credential you, but they'll be you're credentialed to work here. You're not credentialed across the board. So going someplace else, you go through the process all over again. So it really just depends. So it's an answer, but a non-answer, I know, but but that's the reality of our world. Welcome to psych, the world of gray, right? Yes.
I think one of the things I want to hit back on was that safety issue. I think that sometimes it could be gloss over it, but actually something terrible happened in North Carolina at the beginning of this year, and that person was a new graduate nurse. She's from Kenya. She was stabbed to death by a patient.
Yes.
So for me, I've always been, I'm trained in systems, right? And I'm thinking about we are all talking about what I should do as an individual, what you should do as an individual. But my thing is usually trickle down, right? What is the system in place that allowed that to happen?
Yeah.
So I think that's the audacity that a place like UNC gave me. I am an advanced practice nurse. that I get to look at the system and demand that and ask questions and put it in writing so that you have enough paper trail. If you want to bury them, you can bury them. So that, like, put it in writing. This is not in place. This is not in place. This is the standard. This is what should happen. So that when, God forbid we get there, but if we do, you have enough paperwork to stamp the RIP. So, but let's not get there, ask the systematic questions of like, what do we do systematically to protect everybody? My experience, my knowledge may just be for me, but what are we putting in place to make sure that the clinicians that work here, psych has the highest rate of violence among every profession. What are we doing to make sure as a system that we are safe and the people that work in these spaces are also safe?
We're advocating. Part of what we're doing is advocating by not going into places that aren't safe. Making it harder for places to hire people if they're not creating safe environments for us to go work in. And I recognize there's a tension there, right? Because people are like, I need a job. I need to provide for my family. I need to provide for this. So we recognize where that tension is, but we also, like, that stuff doesn't change just because out of the goodness of their heart, they're like, oh, we care about keeping people safe. They care about having staff, right? But if people won't go work there because it's not a safe place for them to go work, and they can't keep providers because it's not a safe place for providers to be, then they have to change. But we have to be okay with being like, this isn't a place I want to go work. That's hard. I know it's hard. But it would also be hard for all of us to read any of your obituaries. I think we have one more
we're
question.
out of time,
Like,
unfortunately.
we're still here, so like, don't worry about it. But yeah.
Thank you so much to our panelists